In 1952, a French naval surgeon named Henri Laborie wasn't trying to cure psychosis, he was trying to prevent surgical shock. He stumbled upon chlorpromazine, which he decided didn't just sedate patients, it made them indifferent to their surroundings. He famously called it a potentiator for anesthesia. When psychiatrists DeLay and Denneker tried it on agitated patients, the results were so miraculous that it sparked the deinstitutionalization movement. But here is the irony. The very success of these early instant-release oral tablets created a new massive problem. Once patients felt better and left the hospital, they stopped taking the pills. By the early 1960s, psychiatry realized it had a revolving door problem. Researchers identified a glaring issue: nonadherence. In schizophrenia, the brain's executive function is often compromised, making it incredibly difficult to remember a daily pill. Furthermore, the first-pass metabolism, where the liver eats up half of the drug before it reaches the brain, meant oral doses had to be high, leading to more side effects. Mid-1960s, G.R. Daniel, the medical director of Squibb and Sons, had an idea. What if we could trick the body into releasing the medication slowly? In 1966, the first long-acting injectable was born, flufenazine enantate, followed quickly by flufenazine decanoate in 1968. Let's look at these two names, enantate and decanoate. Chemically speaking, these are both esters. In pharmacology, an ester is a compound formed by a reaction between an alcohol, in this case the neuroleptic molecule, and a carboxylic acid, which is a fatty acid chain. Think of the ester bond as a chemical lock or a tail attached to the drug. While this tail is attached, the drug is a prodrug. It's essentially inert and cannot cross the blood-brain barrier. The body has to use enzymes called esterases to pick the lock, snip off that fatty acid tail, and release the active medication into the bloodstream. The enantate is a 7-carbon chain, while the decanoate is a 10-carbon chain. In the world of pharmacology, the length of the chain determines the drug's hydrophobicity, or how much it hates water. Because the decanoate chain is longer, it is more lipophilic or more hydrophobic, meaning it stays bundled in the oil depot even longer than the enantate. In practice, this meant that while enantate typically lasted about 2 weeks, the decanoate variety proved to be more stable and longer lasting, often extending the window to 3 to 4 weeks. This small chemical tweak in the chain length effectively set the standard for the monthly injection we still use today. At this time, the idea of an injection for the mind was so foreign that many doctors were skeptical. Up until then, injectable depots were mostly used in gynecology for hormones. The researchers essentially wrapped the antipsychotic molecule in this fatty acid chain and dissolved it in sesame oil. When injected into the muscle, the body slowly nibbled away at the oil, releasing the drug over weeks. It was quite literally a time-release oil slick in the deltoid. Before we look at the specific drugs, it is worth mentioning the variety of chemical strategies pharmaceuticals use to achieve this slow burn. The earliest method was esterification, which was just touched on, where the drug stays trapped in an oil-based depot. Later, we saw the advent of polymer microspheres, tiny biodegradable cocoons made out of PLGA, a type of surgical suture material that encapsulated the drug and released it as the shell slowly dissolves. More recently, we moved to crystalline nanotechnology and aqueous suspensions. Here, the drug is ground into microscopic nanocrystals that dissolve at an incredibly predictable, slow rate in the body's natural water content, allowing for much larger intervals between doses without the need of an oily vehicle. Looking at the specific detail improvements as each major player hit the market, we see a clear evolution. Flufenazine in 1966 and haloperidol decanoate in 1980s were the first generation workhorses. Their goal was simple: survival outside the hospital. They bypassed the liver first-pass metabolism, providing a more stable blood levels compared with the peak and valley effect of daily oral dosing. Risperdal Consta arrived in 2003, and it was a game changer. It was the first atypical or second-generation long-acting injectable. Unlike the oil-based predecessors, this used the microsphere technology I mentioned earlier. It aimed to reduce the stiffness and tremors associated with older medications. In 2009, Zyprexa Relprev, olanzapine palmoate, came on the market with a very specific challenge. While it offered the powerful efficacy of oral olanzapine, it introduced a unique safety protocol known as PDSS, post-injection delirium sedation syndrome monitoring. Because of the risk that the medication might enter the bloodstream too quickly, causing sudden intense state of sedation or confusion, the treatment came with a strict mandate. Patients must stay at the clinic for at least 3 hours of observation after every shot. It was a high maintenance detail, but for those who failed on other medications, it provided a vital safety net. Invega Sustenna also arrived in 2009, and later Trinza and Hafiera, moving to nanocrystal technology. The specific improvement here was the elimination of a loading dose with oral pills. They eventually offered 3 months and 6 months window. The goal was freedom. The patient only had to think about their illness a few times a year. Finally, Abilify Maintena and Aristada utilized partial agonism. Unlike others that simply block dopamine, these act like a thermostat, turning dopamine down when it's too high and up when it's too low. The specific improvement was reducing the emotional blunting or zombie feeling patients often reported with oral versions. Over the decades, the popularity contest of these injectables has shifted dramatically. In the 70s and 80s, the market was dominated by first-generation oily depots like Haldol and Flufenazine. However, as the second-generation atypical long-acting injectables proved to have a more favorable side effect profile regarding movement disorders, the older drugs began a slow decline. At present, the global market is heavily dominated by the paliperidone family, specifically Invega Sustenna, and its longer-acting cousins. Their ease of use, requiring no oral lead-in, and offering extended dosing windows has made them the most predictable long-acting injectables in many developed healthcare systems today. Though Abilify's long-acting versions are rapidly closing the gap. What does the academic literature tell us after decades of use? Research, including the landmark Cochrane reviews, a meta-analysis by Leucht et al., shows a consistent trend. Long-acting injectables are significantly superior to oral medications in preventing rehospitalization. In mirror image studies, where researchers look at patients' life before and after switching to an injection, the reduction in relapse is often as high as 70%. There is a fascinating find called the acceptance paradox. Doctors often assume patients will hate injections, viewing them as a chemical straitjacket. However, surveys of patients actually using them tell a different story. Many patients report feeling less like a sick person because they don't have a pill box on their nightstand reminding them of their diagnosis every morning. The primary problem researchers found wasn't the drug efficacy, it was the clinician bias. We were the ones afraid of the needle. The patients were often just happy to stay out of the hospital. Given the success of long-acting neuroleptics, you might wonder why we don't have monthly injections for depression or anxiety. The reality is that the research is there, but the clinical need is different. While a missed dose of an antidepressant is problematic, it rarely leads to the immediate catastrophic loss of reality testing seen in a schizophrenic relapse. Furthermore, the chemical nature of many SSRIs and benzodiazepines make them harder to esterify or turn into slow-release crystals without affecting their safety. There have been experimental trials for injectable antidepressants like mirtazapine and even implantable pumps for certain medications, but for now the pharmaceutical industry has decided that the needle-to-benefit ratio just doesn't justify the cost when compared to the high stakes of psychosis management. The journey from Laborie, surgical shock experiments, to 6 months nanocrystal injections is a testament to psychiatry trying to bridge the gap between science and real life. Oral medications work in the lab. Long-acting injectable work in the grocery store, at the job, and in the home. By stabilizing the peaks and valleys of medications, we didn't just solve a compliance issue, we gave the brain a steady environment to actually begin the process of recovery.